Well, having said that, one of the things we have really been able to build and really think about how we're doing vaccinations is that we've expanded the eligibility, and we're working with our coordinated local jurisdictions to really have a concerted conversation about what eligibility should look like. So we do have new recommendations, and I'll just read them very quickly. There are 8 considerations for individuals who should be vaccinated for Geneals. And one is people who are confirmed to have high or intermediate risk contacts and with someone with monkeypox, and often that is being evaluated by epidemiologists between multiple jurisdictions. It could be Harris County, Fort Bend, Chambers, but as the epidemiologists identify someone who's a close contact, they're recommended to get vaccinated. People who have attended an event or a venue where there's been a high risk of exposure to someone with confirmed monkeypox virus through skin to skin or sexual contact. Again, this is usually through epidemiology, coordinated efforts to do vaccine coordination. Number 3 has been the most recent expansion, listening to our partners, listening to you, thinking about equity. And number 3 now is all people of any sexual orientation or gender who recently have had multiple sexual partners, including anyone currently considered high risk. So those groups were gay, bisexual, or other men who have sex with men, transgender women, or individuals with a partner suspected of having monkeypox due to a rash or to sores. Number 4 is sex workers or any sexual orientation or gender. Number 5, staff of any sexual orientation or gender at an establishment where sexual activity occurs, like bathhouses, saunas, and sex clubs. 6 would be persons who are HIV positive or those persons who are on HIV prophylaxis, pre-exposure prophylaxis or PrEP. Number 7 would be anyone diagnosed with chlamydia, gonorrhea, or early syphilis within the past 12 months. That was changed from 3 months to 12 months. And then the last group is anyone who has been recommended by their provider to receive the Geneals vaccine due to an immunocompromising condition. And this came to light because we know there are patients who have been vaccinated with their first dose of Geneals, have then been identified to have monkeypox. And according to CDC guidance, the second dose of Geneals would be recommended if they have an immunocompromising condition. So we're asking that you as the provider, if you check that for your patient, if they fit that category, the health department will just receive that attestation, and then your patient will receive their second Geneals vaccine as in accordance with what the CDC has been recommending for immunocompromised patients who had their first Geneals, got infected, but would benefit from their completing the entire Geneals series. I would also like to say before I switch over to Kirsten, who will be giving some data updates, we also will have today speaking to us after we give you some data updates, we'll have Dr. Ann Kimball. Dr. Ann Kimball is presenting to us from the CDC, and she's going to just go over some high-level overviews and maybe some case considerations because they really are hearing from us and hearing about some unique considerations with cases that may be a little bit difficult to decide about, thinking about the diagnosis of monkeypox. Dr. Kimball did her residency in pediatrics at Emory in Atlanta, and then she trained in epidemiology through the CDC's Epidemic Intelligence Service. She's worked the STD and HIV as well as multiple responses with the CDC, including their COVID-19 and their monkeypox response. She's also worked clinically in the outpatient setting and inpatient pediatrics in Atlanta, and she's been on the CDC's clinical consultation team for the monkeypox response since early August. So after we do our data, then we will be inviting Dr. Kimball, and she'll give some remarks. Thank you all.
Thank you, Dr. White. It's always good to hear from you. I do want to point out to the group that all of those vaccine eligibility requirements are posted on the Houston Health Department Monkeypox website, and I dropped that in the chat. All right, take it away, Kirsten.
Hey, good morning, everybody. It is good to see you virtually again. Let me go ahead and get this up. Oops, that's the wrong one. There we go. So with Dr. Kimball here, we're going to try and hop through these fairly quickly. So I'll go ahead and get started. As we do, we always start globally and work our way down, right? So we are up to globally 64,000 cases, which is an increase of about 7,000 to 8,000 since the last time we spoke. The US has the largest number of cases, followed by Spain, Brazil, France, and Germany. Globally, we've still seen less than 20 deaths, with a little over half of those, or about 20 deaths, a little over half in locations that historically report monkeypox, with one confirmed death here in the United States in California that's been confirmed to be associated with monkeypox. Get these going. If we drill down into the United States, we have about 24,000 cases. And the states with the highest number of cases continue to remain California, New York, and Florida, with Texas in 4th place. As we look at testing a little bit, this is sort of cumulative testing, so we can see again where testing capacity increased with those commercial labs coming online. The positivity rate currently cumulatively at the national level is 28.6%, and if we really look in the last 7 weeks or so, that weekly positivity has been ranging from about 21% to 25%. We're seeing a slight increase right now, but that data for that last week is incomplete. The other thing I've noticed, and this is something that we see locally as well, is that we've seen a drop in testing demand over the last month or so. Again, if we look at the United States, the population demographics remain for the most part stable, right? It's being diagnosed primarily in men in that young to middle-aged adult category. And we do continue, if you looked over here on the race ethnicity, to see an increase in the proportion of Black persons testing positive over the course of the outbreak. And then finally, if we drill down, oops, I'm a little ahead of myself. If we drill down into Texas, we've got a little over 2,100 cases, again, most between that ages of 18 to 49, predominantly male. Again, as expected, the cases are clustered in our metro regions, primarily up in the 2-3 region, which is the Dallas-Tarrant County area, or in what we call the 6-5 South region, which is the Houston-Galveston area. And Houston does account for 27% of all cases reported in Texas. So I'm going to go ahead and turn it over to Kamal to talk a little bit about our local data here in Houston. Oops, Kamal, I think you're on mute.
Sorry about that. Good afternoon, everyone. I'll just go ahead and briefly go over some of the statistics that we're seeing for the city of Houston. So currently, as of Friday data, the 7-day centered positivity rate for the city is at 46.7%, which is a slight decrease from the previous week's positivity on 9/5, which was 50%. You can see, as Kristen mentioned, that the number of people tested has slowly been decreasing, and we always see these decreases over weekends and holidays. Next slide, please. And so here we're seeing the cumulative monkeypox case counts, which is this pink line, as well as the number of new cases reported by day, which are the white bars. And you can see towards the past week or so, it seems like it's slowly starting to flatten out. So that could be a good sign in that we're seeing a slowdown in new cases being reported. Next slide, please. When breaking down the case counts by demographics, as of 9/16, the total case count in the city of Houston was 586. The trends that we're seeing by demographics are remaining consistent and similar to those that we're seeing reported by CDC and DISHs, with most cases in the 20 to 39 age group, most cases in the male population, and cases by race and ethnicity also remaining pretty stable over the past few weeks. Next slide, please. Similarly, when looking at it spatially, we are seeing most cases kind of in the downtown, midtownish areas, the most frequency of cases, and the distribution across the city has also been remaining fairly stable. Next slide, please. When looking at a combination of monkeypox and HIV positive individuals, again, about 39% of monkeypox positive individuals are also HIV positive, and that percentage has remained stable over the past several weeks. Similarly, there are about 20% of the positive monkeypox positive HIV individuals who are continue to be not virally suppressed. And these are populations that might be a little harder to reach for vaccination because they may not be seeing their provider regularly. Next slide, please. Some new information that we're introducing as part of the presentation this week is vaccinations. So almost all of the vaccinations are amongst the male population, which makes sense considering almost all of the cases are also amongst the male population. And similarly, over half or the majority of vaccinations are within that 19 to 39 years age group, where we're seeing the most cases. Next slide, please. When comparing cases and vaccinations by race and ethnicity, you can see there's a little bit of disparity amongst the Black and African American populations, where about 35% of the cases are within the Black African American populations, but so far only 16% have received a vaccination. The Hispanic Latino populations, on the other hand, seem to be doing a little better in the sense that while only 23% of cases fall within that demographic, 31% of vaccinations are amongst the Hispanic and Latino populations. And when looking at vaccination counts just overall, just over 6,000 individuals have really received at least one dose, which is up from about 5,500 last week. Of those individuals, just under half have received their second dose or completed their series. And there's a mean days between doses of about 28.6 days. And there are about 1,300 individuals who are past their due date for their second dose. So you can see the chart kind of just shows the purple line is, or the purple bars are the first doses, the blue teal lines are their second doses, the pink lines or bars, excuse me, the bars are past due, and the orange bars are what we're projecting to be the counts for the second doses on those days. It for the data that we have to present this week. Thank you.
Esper72@gmail.com.
NANCYESPER.
Right.
Hey. All right, thank you for that wonderful information. I think we are a couple minutes ahead of schedule, so if there are any questions for Dr. White or any questions on the statistics, we can field a few questions now before we move on. Not seeing any hands up, so I would really excited about our next guest. Welcome to Dr. Kimball. Oh.
I do see someone raise their hand. If you guys want to address that while I'm getting my slides pulled up, potentially.
Sure. All right. So Guadalupe, good question.
Yes. Hi. Good afternoon. Just a quick question. If someone has, they've had monkeypox and they've fully recovered, is it recommended that they get vaccinated?
So Guadalupe, at this time, the CDC's guidance doesn't really account for having been infected, but not starting a series. But again, I know it's what we kind of know now. So I'm going to make a note to see has anything changed in the current guidelines, but I hadn't seen that. What I did see is only if the person received their first dose, was infected, and hadn't completed the series, there was consideration if they have an immunocompromising condition, then they should complete the series.
Okay, thank you.
Welcome.
All right. Well, we're really happy to have you, Dr. Kimball. Please, the show is yours.
Okay, thank you. So first of all, hi everyone. Thank you for the opportunity to come speak with you today. I'm going to run through kind of like a general overview of what our clinical consultations team at CDC kind of thinks that all healthcare providers should know about monkeypox. And then I have a few cases that I can walk you through that highlight some important points. And then if there is time for questions afterwards, I'm happy to take those. Let me move along. So this was just my one slide on Epi. You guys just covered that. I think the only thing to add, the national picture, we have seen a plateau and starting to see improved case counts. So hopefully that continues. So I think, the kind of the two main things, or no, let me start over. The three main things I want to cover today is one, like kind of who to test, which goes along with how to recognize monkeypox, and kind of thinking through a differential diagnosis and, if there's anything else going on. And then the final thing is thinking about treatment considerations and who you might want to treat with antivirals. So we will run through all of that. So first off, testing, should be offered for patients who have a rash that is consistent with monkeypox. I'm going to describe this, but then show you guys some pictures in a second. So typical monkeypox lesions are firm or rubbery. They're well circumscribed. They are relatively deep-seated, so they're not superficial. And then usually they go through these stages, which I will show you in a second. And oftentimes when they're in the pustular stage, there will be an central umbilication. So just kind of some things to think about. That's how monkeypox typically presents. Some patients will have a prodrome and some will have concurrent systemic symptoms, which may include fever, malaise, headache, lymphadenopathy. This does not happen in a lot of patients, but it can. And then it's important to remember that the rash that is associated with monkeypox, could be confused if rash is caused by other infections or caused by non-infectious processes, such as like poison ivy or, drug rashes, at least in some of the different stages of this illness. A few things to definitely keep on your mind in terms of the differential diagnosis would be secondary syphilis, especially in the earlier, more macular-papular stage that monkeypox can have, HSV and VZV, because there is a potential vesicular stage that monkeypox can have, molluscum contagiosum with that central umbilication, enterovirus, so a picture of like hand, foot, and mouth disease, again, which is usually more of a macular-papular rash, and even something like scabies, could be on the differential. I do want to encourage everyone to remember that co-infections are also possible. So somebody can have both monkeypox and something else. So especially if you have a patient who has had a sexual exposure that may have led to monkeypox, when you are testing for monkeypox, please also test them for HIV, for syphilis, and for other STIs, as well as other things that may be on the differential diagnosis, because that'll be a lot more helpful, to get all of that information back at the same time to help guide your management. And then this was kind of covered earlier as well, but just wanted to reiterate that while most cases in this outbreak have occurred among gay, bisexual, and other men who have sex with men, anyone can get monkeypox through close physical contact with someone who has monkeypox or through exposure of contaminated materials. So in terms of identifying monkeypox, you should definitely have a very high clinical suspicion in someone who has a characteristic rash, as well as the epidemiologic criteria. And the main criteria that I wanted to highlight, which are kind of the most important ones for this current outbreak in the United States, are one, having contact with a person who had a similar appearing rash or who has actually been diagnosed with monkeypox, or having close or intimate in-person contact, kind of with people who are in a social network where there is high monkeypox activity. So in particularly right now, this includes men who have sex with men. So these are kind of the two main things that we think of in terms of having an epidemiologic link. In terms of the characteristic rash, so these are all the stages that I mentioned earlier. I do want to highlight this is kind of the typical presentation. There's definitely been a lot of situations, even that I'm aware of, where where we've been consulted at CDC, where things did not go like perfectly in this pattern with this timeline. But I think it is good to kind of remember that typically monkeypox progresses through these different stages over time, and typically the rash, most of the lesions are going to be in the same stage at the same time. So it's very unlikely to see, some that are vesicular, some that are papular, some that are scabbed over, and to have that all be monkeypox. It's possible that that person has monkeypox, but they may have something else going on too. So kind of the general pattern, there can be an anthem that happens initially. And, this kind of mentions oral lesions, but I would also add here that genital anal lesions, could show up really early as well, depending on the route of exposure. So then you may see a macular rash, and then it may become papular, so a little bit raised. Then it may become vesicular, and then it becomes pustular, and it can stay pustular for quite a long time. And this is when you'll usually see that umbilication as well. And then later on, they will scab over, and then eventually the scabs will kind of separate from the skin, fall off, and then you'll have healed skin underneath. If the person is recovering and their immune system works and they're healing kind of as we would expect. And it's not until those scabs have come off and there's healed skin underneath that the person is thought to be no longer infectious. So I have a few pictures here. So these are from the New England Journal. I have one case where we had permission from the patient to be able to show the pictures, so I'll show you that in a little bit. The rest of the pictures that I've included are either ones that are on CDC's website or from an article in New England Journal of Medicine, but I do think that they are valid because at least almost all of the cases of monkeypox, that I have seen do look like this. So there's a couple of different kind of versions. You can see a lot of these are in this pustular stage here. This is a severe case where there's even a little bit of kind of central ulceration or necrosis going on. And then these two lower right images are some of the earlier stages of monkeypox. This is also from the paper in New England Journal that highlights oral lesions. First picture, again, this is a pretty severe case of monkeypox. We've seen pictures similar to this in people who are immunocompromised, either from advanced HIV with low CD4 counts or from other lead to immunocompromise. You can see there's kind of a central umbilication. Some of these are kind of starting to crust over. And then there are some oral lesions too, which can look a little bit more ulcerative, that is helpful to keep in mind. And just from looking at this, it would be really hard to know if that's monkeypox or if that's a variety of other viral etiologies. So that's why swabbing these lesions both for monkeypox as well as for other things on your differential is going to be really important. And then, finally, one last kind of set of images from the New England Journal, which I included the link at the bottom here. So these are some perianal, anal, and rectal lesions. I do apologize for the busyness of this slide. I probably should have split it into two, but I think it's a lot of really helpful information all in one place. So in terms of treatment for monkeypox, the vast majority of people will improve on their own. It's can be a relatively mild self-limiting disease in the majority of people, but there are situations where treatment should be considered. So first is in the case where somebody actually has manifestations of severe disease. So there's hemorrhagic disease, there's a large number of lesions that have become confluent, there's sepsis, encephalitis, actual involvement of of the eye causing ocular monkeypox, or involvement around the eye where we're really concerned that it could get into the eye, could cause corneal scarring and loss of vision. Or kind of any other reason why the person is hospitalized. If they have severe proctitis, and severe pain, that would be an indication to go ahead and start treatment. And then second, if there are anatomic areas involved that could lead to serious sequelae, particularly scarring or strictures. So pharyngeal involvement, penile involvement, vulva, vagina, urethra, rectum. With our consult service at CDC, we usually are called when there are severe cases and where providers and health departments are looking for additional therapies. And we have seen situations where people have developed urethral strictures requiring suprapubic catheterization, lesions and inflammation in the rectum that lead to obstruction. So it's very, very rare, but it is possible. And then another important thing that is more common is a secondary bacterial skin infection of the monkeypox lesions. And then, so those are kind of all like, we already have severe manifestations. And then there's this second category where we can consider treatment and people who are at high risk for these severe manifestations. So most importantly, number one is people who are severely immunocompromised. This is the population that we have seen the majority of these severe manifestations in this outbreak thus far. And most often it's been men who have advanced HIV and low CD4 counts. But we have been consulted on cases who have, cancer, solid organ transplantation, other reasons for severe immunocompromise. Potentially considering treatment for young children. The data that's driving this 8-year cutoff is based on some data from endemic countries in Africa specifically. So we're currently kind of pulling together all of the cases that we've seen in the US in children and trying to better summarize the severity, to see if we have any additional information to kind of characterize that. There's concern that pregnant people can have more severe disease, and then people who have conditions affecting the skin integrity. So that can include like severe eczema, burns, severe acne, that kind of stuff. So kind of similar to the complication of HSV, which is eczema herpeticum. A similar thing can happen with monkeypox. So then in terms of treatment, our first line treatment is going to be tecovirimat or TPOXX. This, the majority of the time is given orally. There is an IV formulation that can be requested, and we've been recommending this, really if there's high concern for absorption issues. So the patient, is unable to take a large fatty meal. The patient has maybe some sort of GI disease, is having a lot of diarrhea, something like that. So if there's really concern for whether or not the oral formulation is being adequately absorbed, then IV would be a great next step. And then like much further down the list, in cases that are with severe disease, it's progressing, it's worsening despite TPOXX, and particularly in people who are immunocompromised. Cidofovir is an option, which does have severe renal side effects, but it's, it could be used for some people, and we have recommended it for some people. And then vaccinia immune globulin as another option. I want to emphasize again, most people have mild self-limiting illness that doesn't require any treatment beyond supportive care, but unfortunately we have seen people where this is not the case. So just wanted to make everyone aware of these different therapies. The vaccinia immune globulin right now is not widely available. It's something that has to be requested through CDC from the Strategic National Stockpile. So if you do have a patient where you're worried you're maybe, moving into this area where you need additional therapies, getting in touch with your health department, who can then get, facilitate getting in touch with us at CDC. Sooner rather than later is the way to go. Usually by the time we decide this is indicated and we order it, it's still going to be 24 hours before we can actually get the medication to you. So now I'm going to go over a couple cases. So this first one was a man in his 50s who does not have HIV, who's actually on HIV PrEP and was very adherent with that. and originally presented with a diffuse pustular rash. They swabbed it. It was diagnosed with monkeypox. I think because of the extent of his rash, he was treated with oral TPOXX for 14 days. And as he was kind of getting towards the end of that 14 days, he returned to care with a worsening rash. And on the provider's evaluation, it seemed like there were, potentially a couple different things going on, some monkeypox lesions that were maybe starting to heal, but then he had this new disseminated macular papular rash. And they actually called us at CDC because of concern for TPOXX resistance, for progression despite TPOXX. And they repeated the monkeypox testing as well as testing for a variety of other potential pathogens, which was fantastic. And his repeat monkeypox testing was negative, and his RPR was very, very high. So this new rash was actually consistent with secondary syphilis, and he improved with treatment of his syphilis as well as completion of his TPOXX. So I know it's, is it Occam's razor, where it makes a lot more sense, and we want to fit everything into one clean bubble, but it is totally possible for people to have multiple infections at one time. So this case kind of highlights that. This second case, and these are all cases that we've seen in the last month and a half, or that we've been consulted for. The second one is a man around the age of 35 who does have HIV and a low CD4 count. He was not on antiretroviral therapy, and he was eventually diagnosed with monkeypox after, unfortunately, having lesions for quite a while because of an initial, I think, delay in care seeking, and then there was also delays in diagnoses because the lesions weren't tested. I'm not sure if this person was upfront about maybe his potential behavioral risk factors for monkeypox, which may have delayed diagnosis. But he was eventually diagnosed with monkeypox. At that point, he needed to be hospitalized for severe genital lesions, for pain management. He was started on oral TPOXX, seemed to be getting better, and was sent home. But then he came back with, he was taking his TPOXX at home. He had worsening lesions that led to kind of like it was like a coalescent necrotic lesion on his back. And then he also had worsening lesions of his penis. He was re-hospitalized, and he had such severe penile involvement that he was unable to urinate. There was a lot of swelling, concern for strictures, so he actually had a suprapubic catheter inserted. He had also developed secondary MRSA infections from his skin, which led to bacteremia and sepsis, and was found to have pulmonary nodules that were suspected to be related to monkeypox as well. His treatment has included a transition from oral TPOXX to IV TPOXX, and now 2 rounds of vaccinia immune globulin, which the treating team and the patient did think helped. And he is improving, but is still hospitalized. And he did allow for some pictures to be shared. So I did want to show, this is a lesion on his back. So by the time, he came into care, he already had this kind of severe ulcerative, really plaque here. So this was, pretty far into his disease. He had had treatment for 13 days, and then eventually he came back in. And this is what we're kind of calling progressive monkeypox. So having the central necrosis and then these new satellite lesions showing up. This kind of picture is something that we have seen in a few patients with a similar story, some delays to care, some delays to starting treatment, and severe immunosuppression related to AIDS. But this person is alive and it seems to be having some slow improvement at this time, which is great. And then I have a third case. This was a person in his mid-20s. And he originally presented with a rash that was very consistent with monkeypox, as well as fever and back pain. Went to either an urgent care or an ER where they did monkeypox testing, and actually sent him home with steroids for kind of unclear reasons. And then the monkeypox test resulted positive, and the provider called in some TPOXX for him to take it home. And he was not known to have any underlying conditions at that time. And then he came into the hospital unfortunately critically ill with a disseminated rash, with sepsis, with altered mental status. Upon hospitalization, they did HIV testing, and he was diagnosed with advanced HIV with a CD4 count of less than 100. And they did treat him with IV tecovirimat, with vaccinia immunoglobulin, for lots of other potential opportunistic secondary infections. And this is a patient who unfortunately did die. And it was thought to be, related to the monkeypox. He likely had, some additional things going on too, but related to monkeypox. So I did want to spend 1 second. So these severe manifestations are very rare, but it is something that, we kind of keep getting called about. So we do want to make sure that providers are aware of what to look out for and kind of what would be, the reason to hospitalize, to maybe switch to IV TPOXX, and consider reaching out to your health department and maybe reaching out to us to talk through potential additional treatment options. So some of the severe things to look out for are these, persistent or progressive lesions despite oral TPOXX, starting to be like confluent, some of those necrotic centers. Those are some kind of signs for more severe disease. Also, if there's lesions involving a lot of the total body surface area, that can be associated with, third spacing of fluid, secondary infections. So kind of like what we think of like burn patients. I mentioned earlier, lesions in sensitive areas leading to gastrointestinal obstruction, urethral obstructions. We have seen a few situations, and there's some reports in the literature too from prior outbreaks of patients developing such severe lymphadenopathy that it could obstruct the airway. Again, this is very, very rare, but we have heard about it. We have seen it. And finally, involvement of multiple organ systems. So I mentioned, possible pulmonary nodules. It's something that, we're working with a few providers around the country to try to better understand what's going on here. Neurologic disease. There was a case series published in MMWR about 2 weeks ago on 2 patients who had kind of like an encephalitis type picture that they ended up thinking was to be more of a post-infectious demyelinating condition. There's been concerns, but for meningoencephalitis, for transverse myelitis, very rarely, but some cardiac involvement. And then I did mention that monkeypox can cause conjunctivitis and can also cause corneal ulcers that can be site-threatening. So to close, these severe manifestations are very rare, but we've seen them most commonly in severely immunocompromised patients. So if you do have a patient who is severely immunocompromised, starting treatment with your first-line therapy with oral TPOXX early would be recommended, and with keeping a close monitoring and then consideration for escalation of therapy. And then definitely, remembering that people who are suspected of having monkeypox, whose potential exposure was sexual, should be evaluated for HIV and for other STIs at the same time as when you're evaluating them for monkeypox. And then, feel free to reach out to your public health jurisdiction or us at CDC if things seem to be going south, and we're happy to, talk through what we've seen. So I will stop there, and I'm not sure if there's time for questions. I focused on, the adult, some of the adult patients, co-infections and severe manifestation for this presentation. I am also the pediatrician for the team, so I've been involved in a few cases related to children or pregnant patients. So if there are any questions about those, I'm happy to try to address them. Thank you.
Hey, thank you so much for all that wonderful information. We really appreciate you being here. And yeah, we're scheduled till 1 o'clock, and we try to leave a good amount of time for discussion and questions. So before we get over to that, I know we had one update from our immunizations team. Kelly, are you on? And
Yes,
that's okay.
yes, I am.
Okay,
Can
good.
you hear me?
Yeah,
Oh,
absolutely.
I'm sorry. Yes. So the update that we had in immunizations, and let me introduce myself first. Hi, I'm Kelly Hartnett. I'm the Community Involvement Coordinator in the Immunization Bureau. And so we worked with our outreach team to update our survey that we we give out to providers who are interested in becoming partner providers with us. And so I Joy was going to put that link in the chat, Joy. But we've updated it, and so it's more current with all of the updates that Dr. White went over. And so we just wanted to make sure that we made that available to all of the providers on here, if any of you are interested in becoming partner providers with us.
Wow.
You
So
broke up a
sitting-
little bit.
That was
but-
all from me, Roger.
Thank you. Yeah, so so there's a Smart Sheet link, and if anyone on this call is interested in possibly becoming a partner to provide Geneals to your clients, go ahead and fill that out, and that'll get to our immunizations team. All right, and I know I saw a few hands up, so we can start fielding some questions. Is that Nancy? Do you have a question?
Thank you so much. And this question is for our local providers. So I am a physician in private practice, and I am not sure how to test. I don't have any testing tools where to send the samples. We use Quest Lab, and we use the Provider Choice Laboratory for swabs for COVID. But I honestly am very unprepared when the first patient walks into my office with symptoms or signs of monkeypox. So what would you recommend for me in Houston, Texas?
Well, sure. So one, my background is in laboratory, so this is something I feel confident speaking to. For collection tools, most cotton or most non-wood shaft swabs and a sterile dry container should work. In a pinch, the same swabs you have for COVID would work, but we are seeing a lot of inconclusive results or indeterminate results because they don't have that a good stiff shaft, so you can get a good vigorous swabbing. But really, all you need is a sterile swab and also a sterile tube. VTM works in a pinch also, but we're also, if at all possible, it should be a dry tube. So like what we call it, like a centrifuge tube or something like that. I know Dr. Siegler is on, who's our laboratory director. Did you want to add anything? Okay, well, and also Quest does perform that testing. But if you need any help, reach out to the health department and we'll get you coordinated with care. Our LRN lab performs that testing. We'll be happy to get you taken care of as well.
Great, I appreciate it. Thank you.
And was that Nancy Esper?
Yes, ma'am.
Okay, so this is Dr. White too with Houston Health Department. I want to make sure we get your information because we have some additional tools on the website, but we have some other resources to your question. So I'll make sure I get your information before we sign off.
Yeah, if you don't mind sending me, because I'm going to call local health. If you can save me the phone call, I would so much appreciate it.
Definitely.
Thank you.
Rebecca, I see you had your hand up for a little bit. Or Joel.
Hi, can you guys hear me?
It's a little faint, but we can hear you.
Okay, yeah, so I have a question for Anne. So I'm not sure if there's enough data out there or anything like that, but what are some things that patients that have already had monkeypox do to prevent reinfection? Or are they, once they have the condition, are they able to get it again? Do they build immunity? Is there anything related to that?
Yeah, so unfortunately, I don't have a perfect answer for that. That is something that's actively being investigated. They're kind of the thought in terms of monkeypox is kind of extrapolating from smallpox. So we are really not sure about how long immunity lasts, about the risk for reinfection. I can say that at least our team has not been made aware of a case of reinfection yet. That does not mean that, that it can't happen. I think that's all I can share at this time, though. I'm sorry. I wish, there's a lot of data gaps and information gaps that, are trying to be filled right now. But I think just, your kind of general guidance in terms of, STI prevention HIV prevention is probably what I would recommend in terms of monkeypox prevention.
Thank you so much for that.
All right, and I just posted a link to our specimen collection guidelines in the chat as well, which are the ones for our LRN lab that will go along with the ones for the CDC. Okay. Any other questions or just anything else you wanted to talk about? You know, this is an open forum where we want to hear from all the people here. Anything that's on your mind. There's a lot of great minds on this call, so I'm sure somebody can help us come up with an answer. Your hand up. That family health? No. Yeah. Do you have any questions?
Yes, one quick question. So I was kind of faced with this situation almost a month ago now, and I did not have any collection tools available. We were coming up on a holiday weekend. I believe that was the last holiday that came up, Labor Day. What other alternatives do we have if we have a suspicious patient? And I did, and actually it was a family of patients who attended a local school in the area who had some type of monkeypox outbreak. Are there any other alternatives that we can send the patient for testing if we're unable to complete it in-house? And if so, what is the process? I did call the city of Houston. I spoke with an epidemiologist, but everything fell apart.
Well, I will say that, you know, our laboratory will, in a pinch, provide collection supplies. And if, as far as where to refer somebody to get tested now, on a holiday or a weekend situation, I guess the Harris Health System would be the best referral, but I'll let Dr. White fill us in on that piece.
Thank you, Roger. Again, it's hard to, you know, when you're looking at the screen, I'm going to put my email in the chat. If you can email me directly after this discussion, because I like to just kind of go through some considerations for you. There are teams that we have when we think about schools and exposures and just like you said with testing, but for your unique consideration with regards to that family, I want to just kind of maybe follow up with you one-on-one. Because I think there's some opportunities for several considerations, even if it's your team being able to do testing and whether or not you have the materials to do a proper sample collection, if that's okay.
Sure, thank you so much.
Okay, I'll put it in. And then I actually wanted to acknowledge Dr. Kimball, because for this team, as you can see, some of the cases that she described, I will say we work with you all very closely, and some of you all had cases that weren't clear how to, you know, what's the next step. We were all coming into this epidemic in such a way that unless you maybe have seen these cases in other worked experiences, if you've done global medicine, it really was a unique consideration. Even as they talked about where the lesions were, you know, face lesions meant something completely different, coalescing meant something different. And so Dr. Kimball and her team have been very helpful in really helping us sort of almost that for many of you know, in medicine, you know, that consult that you do a consult to a team to say, okay, you're our infectious disease consult. Can we run and discuss this case with you? Can we get your experience? And what's unique about Dr. Kimball is, yes, she's hearing cases from our jurisdictions, but she's hearing from all over the country that's shaping her guidance as we talk about some of the cases. And it's been really eye-opening. Some of the cases weren't really clear-cut even when we got off the call with the consult. But what the CDC has been very helpful in helping us think about is, okay, let's follow back up in 24 hours. Let's follow back up in a couple of days. And they kind of walk through the decision tree. And to her point, we've had to think about TPOXX. We've had to transition to IV based on their recommendations. We had to think about Cidofovir and VIGIV, and it's been really nice to have her team sort of think about some of these unique cases. So I'm glad, Dr. Kimball, you did mention, I hadn't heard of the urethral stricture, and in that light, I know some of our partners here have, to your point, been very leaning forward with co-infections, and they actually are checking for monkeypox and looking for other co-infections. And I don't know if we were thinking about that way very early in this outbreak. And so you're just reinforcing really what I think a lot of the providers on this call are currently doing. And you're reinforcing that they should just keep continuing that, because again, those cases that you presented were very unique. And again, common things are common, but thank you so much for the case discussion. It's very helpful.
Yeah, thank you for inviting me. I just want to echo, what you just said. This is really challenging. It's except for a very, very small number of people who have had experience with monkeypox, or prior experience with smallpox. This is a new disease for most of us. So, we at CDC are honestly learning along with you, but at least, we have the opportunity to hear about what's going on in lots of different places around the country, and at least be able to provide a little bit of insight in terms of what other people have seen and, what they've done. So,
and I don't think
great
you
job,
can see
everyone.
the chat.
I can't. Yeah, I mean, this is all very, very challenging. So
yeah, I don't think you can see the chat, but already people have been reaching out. Like, the pictures were phenomenal. Somebody says, I work in the emergency department, so these pictures will help me teach my team how to think about if you see a lesion that looks this way. So thank you for sharing those pictures.
Yeah, I'll put again, I mean, only one of those pictures, came from a patient. We are in the process of trying to get approvals from some additional patients to pull some additional pictures. But most of the pictures I shared are from published materials. I'll put the links to those in the chat in a second, to the New England Journal paper, and to CDC has a webpage on clinical recognition that has a lot of great pictures too. So I'll make sure those are available for you.
Roger, I might also add that we did have a presentation on September 9th that included references to collection, and there are some references there to videos on the collection.
Great, it's a good point. So Dr. Siegler, our lab director, is making reference to one of our earlier forums, and those are available on our website. That I believe Kirsten put that in the chat also. So we have two. This is our third forum. In the first forum, we had a nice piece about laboratory services, collection, and some background on testing. We are almost running out of time. We got a few minutes left. Before we get off, I want to just thank everybody for coming. Please come back on October 7th, when our plan for our next forum is to really put the spotlight on TPOXX. We'll hear from Dr. Michael Fisher from the Texas Department of State Health Services, as well as Dr. Timothy Wilkin of Cornell. Dr. Wilkin will be sharing some information about the STOMP project, which is the study of tecovirimat for human monkeypox virus. More information about that is available at the stomptpox.org website. And I am told that there will be at least 2 local sites for this project. So if you want to get patients enrolled, please tune in and get more information. As always, everyone's welcome here, so please share this invitation widely. We don't care where they're from, as long as you think they can get value from this. Please include them. And also, if there's any topic that you want to see covered, let us know. At the end, this is your forum. We're just trying to add value to your day. So I want everybody to have a wonderful weekend, and thank you for doing what you do. All right, we appreciate it. Thank you. And always special thanks to our guests. We really appreciate all the value you add. Appreciate it.
Again, thank you, everybody, and thank you, Dr. Kimball. Have a good weekend.
Yeah, thank you for having us. Have a good weekend, y'all.
Thank you.